Welcome everyone to this special Zoom event presented by the Friends of the Needham Public Library. I'm Margaret Pantridge from the Friends Program Committee. Today, the Friends are pleased to present Dr. Franklin King IV, who will speak to us about the psychedelic renaissance. But first, a few housekeeping items. This program is being recorded and will be posted on the library's website. We've muted everyone during the presentation, and we ask you to turn off your video cameras just while the presentation is going on. And then afterward, Dr. King will take questions. And at that point, we encourage you to turn on your cameras, please. And you'll be able to ask questions live if you like, or else to ask them through the chat line. We'll conclude the program by 3:30 at the latest. I'd like to thank Gay Ellen Dennett from the library staff, who's our technical director today. Now on to the program. Dr. King practices at Massachusetts General Hospital, where he's a staff psychiatrist at the Center for Anxiety and Traumatic Stress Disorders. More to the point for today's program, he's also Director of Training and Education at the Center for Neuroscience of Psychedelics at Mass General Hospital. The center's mission is to understand how psychedelics enhance the brain's capacity for change, to optimize current treatments, to create new treatments for mental illness, and to make the term treatment resistant obsolete. Dr. King is a graduate of Brookline High School, Connecticut College, UMass Medical School, and he completed his residency and fellowship in psychiatry at Mass General Hospital. Please join me in welcoming Dr. King to the Needham Free Public Library. Franklin?
Thank you, Margaret. Thank you all for coming. Thank you to the Needham Library for having me. Let me just share my screen here. Okay. And Margaret, sound's coming in okay?
Yeah, sounds good to me.
Good. Okay, so very pleased to talk about psychedelics. It's an area I've been interested in really for a very, very long time. And kind of, I guess I could probably talk a little bit about why I'm interested in them at the end of the talk. But briefly, I kind of went into residency wanting to do research on psychedelics. And after a couple of dead ends, there really weren't any opportunities back in 2013 to do anything, and kind of made enough noise about it over the 4 years of residency through 2017, where I had the opportunity to do some training in the MAPS MDMA therapy training program in 2016. And through sort of some turns of events, really through this panel at the Broad Institute that the then chair of psychiatry came to, and heard some stuff that was interesting to him about psychedelics potentially modulating rumination and depression, led to the idea of a study which is hopefully about to start at MGH. And that was about 3 years ago. And kind of in the ensuing time, there's been a whole bunch of other stuff that's happened. We have a number of studies at MGH that are in various stages of development. We actually had our formal launch event for the center just last week with Michael Pollan. So it's really an exciting time, especially for me, since this sort of interest that I've had for so long is
Franklin,
now.
Could I interrupt you for a second? I'm sorry, I'm
Yes.
hearing from some people that they can't hear. Will everyone who can't hear raise their hand? Can most people hear?
Let me.
Thumbs up if you can hear. Thumbs down if you can't hear. I guess most people can hear. Gay, do you have any comments on this? This must be a problem with people's settings on their computers?
I would assume it is a problem with settings at this point, because I'm hearing it just fine.
Okay. I'm sorry, everybody. You should, those who can't hear, please go to sounds in your computer settings and see if it's on or not. And I think we'll have to continue with the program. Sorry about that. Go ahead, Franklin. I apologize for interrupting.
Sure. So anyway, I was just saying a little bit by way of an introduction. Essentially, this is an area that been sort of interested in for a long time, and finally it's kind of taking off in MGH. So really exciting for me to sort of be able to participate in this. I'm going to talk today, I'm going to try to actually keep it short. Hopefully there will be some questions and discussion at the end. So I'm going to talk, basically give a little bit of introduction, a little bit of kind of the medicine behind this, couple of slides on how the therapy works. I'm going to go through some of the clinical studies and then a little bit of the neuroscience at the end. Okay, so starting off just from definition. So probably a lot of you have read the book from Michael Pollan, How to Change Your Mind, where they talk about the sort of heyday of the early days of psychedelic research in the 1950s, where there were a lot of different terms used for psychedelics, but finally kind of settling in 1956 on the term psychedelic itself, which meant mind manifesting from the Greek. That was what one early researcher thought that they did. And I think I put the sensory experiences down here at the bottom on purpose. Really, the main thrust of what psychedelics do and how they work is that they elicit a change in consciousness, a very profound change in consciousness. And this leaves the person who's had the experience that something, the idea that something very profound and transformative has happened, and oftentimes sort of tagged with the feeling that it was spiritually important or mystically important, very personally meaningful for the individual. And alongside that is this concept of ego dissolution, which is a little bit difficult to kind of explain, but really what it refers to is this dissolving of the feeling that there's a boundary between the self as a discrete entity and really the rest of the world. And so people can have all sorts of what are called transpersonal experiences, where they can be identified with other people. They might feel that they're just sort of much more in union with the rest of the world. There might be identification with an animal or even with an inanimate object. And all this kind of falls under this notion of ego dissolution. Okay. Finally, this idea of increased sensory experiences. So synesthesia is the experience of multiple sensations kind of together. So people can sort of see sound or smell something visual. And there is a heightening of visual imagery and sort of a distortion of the visual field such that you might call it like hallucinations, but unlike true hallucinations, which are what you see in psychosis, where people actually are not aware that these are not real. This isn't a psychotic state, and it's not a true hallucination. People are well aware of the fact of sort of what they're seeing is part of the drug experience. And I put this down on the bottom on purpose because I think in the media, in cartoons and the like, you often see people, you know, taking LSD and they're sort of looking at butterflies and like running after insects that aren't real. And this is really not what happens with psychedelics. And it really also, more importantly, is not the primary thing that people in all of these studies that I'm going to talk about take away from in terms of the aspect of the drug experience that really sort of helped them get through their depression or get through their addiction or sort of what was most important to them. So I try to sort of downplay that. And that's also why I don't use the term hallucinogen, which is sort of a competing term for psychedelics. In terms of when I say psychedelic, the specific drugs that I'm talking about, there's sort of two classical serotonergic psychedelic families. One are the tryptamines and the other are the phenethylamines. Okay, so the tryptamines are essentially modeled, all of them are very similar to the molecule serotonin, which is a neurotransmitter. So those include LSD, psilocybin, that's the ingredient in magic mushrooms, and finally DMT, which is the ingredient in ayahuasca. The phenethylamine groups are all very similar to the chemical amphetamine or methamphetamine. That doesn't necessarily mean that they're like speed or like a stimulant. They're just a different family with a different chemical structure. And there's a lot of different psychedelics in this family as well, but the most commonly known ones are mescaline, which is in peyote cactus, and MDMA or ecstasy. And really that's kind of what I'm talking about in this talk, these two families. I'm not going to talk about ibogaine, which is structurally a little bit different, works a little bit differently, but is definitely a psychedelic by most people's definition. And I'm not going to talk about ketamine, which has really sort of garnered a lot of attention recently for sort of treating depression rapidly and for reducing suicidal thinking rapidly. It's quasi-psychedelic, but it's constitutionally different from these other ones. So in terms of the pharmacology, psychedelics are basically very similar. Now, there's some qualitative differences between psilocybin and LSD, but really the major thing that differentiates them is duration of effect, right? So LSD is on the longer side, peak effect 6 hours, but really a sort of whole LSD experience is going to be about 12 hours. That's a long time. You might think, or you might, it might make sense to think that if you're studying this clinically, it's a little bit more difficult to work with. You need to have a therapist, at least one, usually two, present for these sessions for the whole time. So a 12-hour day, not including sort of like introductions and getting all the research paperwork signed and sending the patient home. You're talking about a very long session day if you're working with LSD. So LSD tends to not be used that much in this wave of research, particularly in the United States. Most of the psychedelic studies other than MDMA have involved psilocybin, particularly in North America and Europe, some with ayahuasca. So those are on the shorter side. Those are really 4 to 6 hours. And the supervision time is usually about 8 hours for those drugs. Now, 5-HT2A is, so 5-HT is serotonin, 5-hydroxytryptamine. And the primary psychedelic effect, or the primary pharmacological effect, is through a specific subtype of the serotonin receptor. That's the 2A receptor. Okay, there's like 20, 25 different serotonin receptors in the brain. This specific subtype gets activated by psychedelics, and that's responsible for the psychedelic effect. We know this. This is very nicely shown. This is a study out of Switzerland where they pre-treated people before they gave them LSD with ketanserin. And ketanserin perfectly blocks only the serotonin 2A receptor. Okay, so if you look closely at that screen, there's not 2 lines, there's actually 3. The y-axis of that screen is how highly people are scoring on the psychedelic experience. So the purple is LSD. As you might expect, they're scoring highly over the course of several hours. And then at the bottom, the placebo and then the ketanserin groups basically are superimposed. So all that shows is that if you gave people a serotonin 2A receptor blocker before giving them LSD, they have no trip at all. It's the same as the placebo. So obviously the brain is really complicated, to say the least. There's a lot of downstream effects that are thought to be involved in sort of all the subtypes of psychedelic reactions. This is another serotonin receptor, 5-HT1A, that's implicated. There's a lot of other serotonin receptors that turn on after you turn on 2A. So there's a lot more research that needs to be done, but the initial effect is clearly through the serotonin 2A receptor. Okay. Tachyphylaxis just means that you can't get a drug effect. All right, and you see this with certain drugs and you see this with psychedelics. And what's interesting about psychedelics is that unlike most drugs or drugs of abuse or drugs that people recreationally do, it's actually impossible to get dependent on psychedelics, because if somebody takes LSD or psilocybin, for example, 2 to 3 days in a row, they're going to be completely locked out. What happens is those serotonin 2A receptors get drawn back into the cell, into the neuron, and they can't get activated anymore for a period of several days. So people really, you can't trip, so to speak. I don't like that term, but you can't trip more than 3 days in a row for most people. Everybody's a little bit different, but people get locked out for about a week with repetitive dosing. So these are not things that you can actually use habitually the way somebody can use methamphetamine or alcohol or opiates or anything like that. Just in terms of the physiological effects on the body, the psychedelics actually are very well tolerated physically. It's interesting that really the main precautions are psychological. Okay, so about half of people will have one of the following. These are, again, most of the stuff that I'm saying today is referring to the results of research studies. So these are, not people taking LSD and seeing what happens when they go to Times Square in the middle of the day. These are people going in for structured research studies with a therapy protocol. But some people will report headache or nausea, usually without vomiting, unless it's ayahuasca, which does tend to make people sick, or fatigue. This feeling of fatigue is actually, it has a special name in the psychedelic community called body load, where people just feel sort of anergic or sort of like wanting to lie down on the psychedelic. So about a little less than half of people will get one of those at some point, but they tend to not be experiences particularly negative. They're not something that people usually take away after the trip or after the experience as something that was really problematic. Sympathetic changes just refers to your sympathetic nervous system. That's your fight or flight arm of your autonomic nervous system. So when you turn on your sympathetic, you increase blood pressure, heart rate, temperature, things like that. There's a little bit of that, but really not to a significant extent. So certain other serotonin drugs can really sort of rev up the sympathetic nervous system. You don't see that too much in psychedelics, just a little bit. So there'll be, a slight increase in blood pressure, usually of like 10 millimeters of mercury. So, somebody might go from 140 over 90 to 150 over 100. Heart rate, usually about 10 beats per minute at most elevated, and a slight increase in temperature. You do see dilated pupils, and people, if you ever did check their reflexes, would have slightly increased reflexes. But really, psychedelics tend to be very well tolerated, including in medically ill subjects. And so there's been a number of studies in terminal cancer patients. There's been some early data coming out starting in 2019, looking at healthy geriatric patients, really finding that psychedelics are very well tolerated in these groups, who you might expect to be more prone to getting side effects. There's really no lethal dose that's ever been established. In terms of deaths associated with psychedelics, those do exist, but those are really the result of behaviors. There's not actually any reports of people who died from ingesting too much of a psychedelic. So we don't actually have lethal doses for the common drugs like LSD or psilocybin. It's probably in grams or even kilograms. And just for reference, LSD is dosed in micrograms, psilocybin is dosed in milligrams. So really a massive amount is what you would probably have to take to actually truly overdose from a psychedelic. And then no evidence for mutagenic effects. That means no evidence that they mutate chromosomes or that they're neurotoxic. For those of you that were around watching TV in the early 1970s, the federal government had a very strong propaganda campaign against psychedelics, and they were showing pictures of mutated babies and mutated chromosomes and things like that. And that was actually pure propaganda. It wasn't based on any shred of evidence whatsoever. So it was just not real. In terms of psychological safety, so psychedelics are interesting, right? And that the risks of an adverse effect really are mostly psychological. And that makes them fairly unique in terms of most medicines that you might work with in a research setting. So what are we talking about when we're talking about a bad trip? This is actually a term that in psychedelic therapy, you really don't want to be using. And I'll explain why in a minute, but essentially psychedelics can induce a variety of sort of negative psychiatric or psychological states. So ranging from fear, anxiety, panic attacks, dysphoria, sort of feeling unpleasant, sometimes ranging into paranoia. Can include a variety of modalities. So people can have fears about their body. They can be sort of misinterpreting sensations, and have negative thoughts about their self, negative thoughts about the world. The reason we really don't say bad trip is that part of the preparation in psychedelic therapy is to help people be prepared for sort of any and all experiences, and to simply remain open to whatever it is that's going through their mind, to be curious about it, to explore it, to sort of move through it. And through that process, that's really where people will come away with feeling that they've really sort of accomplished something or developed an understanding about something about themselves. And for that reason, the primary intervention, whereas usually, if you're sitting with a subject in a medical setting and somebody's having a panic attack, you would treat it with a medication. That's sort of our Western medical model. But with psychedelics, really the primary intervention is sort of, number one, having already prepared the patient to sort of be curious about it, be open, try to not fight the experience. And number two, to talk about it. And the therapists are there to sort of help the patient talk through this and move through whatever this may be. So usually, and only in very rare instances, are medications, like Ativan, provided to a patient in these research studies, despite the fact that it's not uncommon for some aspect of the trip to actually be a difficult one. So psychedelics are not without their risks, other than ensuring that they're being provided in a safe and controlled setting. There are some risks in some people that probably shouldn't, at least at this stage of research, based on what we know and what we don't know, people who shouldn't take it. So there's one subject in a research study from the 1960s who developed a period of prolonged psychosis. We don't have any further details on that study. It's an old paper, but that subject's twin had schizophrenia. There's a variety more of sort of anecdotal reports. I mean, I've certainly seen plenty of people coming into the emergency room who might have developed a manic episode or a psychotic episode in some temporal relation with having done a psychedelic. And so at this point, we do sort of consider having a personal history of psychosis or mania or a primary relative, so brother, sister, parent, or child, who has a history of a psychotic or manic episode who really probably shouldn't be given psychedelics. So all the studies that you hear about people with that history have been screened out. They're not allowed to be in the studies. HPPD stands for hallucinogen persisting perceptual disorder. And that's just a fancy term for flashbacks. It's the medical term for flashbacks. This idea of flashbacks is interesting. So plenty of people have reported sort of persistent perceptual disturbances after taking a psychedelic in the community. But there's also been thousands of study subjects, both in the 50s and 60s, and also more recently in the last 20 years, who've been given psychedelics. And this has never actually been reported after anyone being given them in a controlled setting. So there's something about this that seems to be real, and it's something that, you know, we've certainly seen plenty of this, but it's never been seen in a controlled setting. So whether it's a question of dose or whether it's more of sort of a traumatic reaction to taking a psychedelic and having a bad experience in a non-controlled environment is unclear. But obviously more research is going to be needed on this. Catastrophic behaviors, things like suicide, jumping out of windows, or just being confused or running into traffic, this does happen. This was part of what sort of brought the curtain down on psychedelics in the 60s. There was a lot of media sensationalism of any time this happened, but there were a number of suicides, particularly in 1969, from some more powerful psychedelics that were even longer acting than LSD. So psychedelics certainly are not without their risks, and really preparation, controlled settings, and psychological support are really critical to ensuring safety. So always want to emphasize that. Now, why are people so interested in psychedelics? Why is there all this hype? Really, it's for these prolonged psychedelic or psychological effects, right? So I think one of the things that is exciting psychiatrists are that you have all of these studies where people are being given psychedelics, and usually it's only 1 or 2 doses, again, you know, embedded within a therapy program. But people are coming in, you know, they're treated for a month, they get 1 dose of psilocybin, and then their depression seems to be cured for at least 6 months out. Or in the case of MDMA, these people who get 3 rounds of MDMA, and then 2.5 years later, they still don't meet criteria for PTSD. So this is obviously incredibly unique in psychiatry, whereas you know, most of our medications, people need to be on them for an indefinite amount of time. And so there's this effect that definitely is long lasting from psychedelics that seems to lead to these prolonged psychological changes, which really is what is sort of driving all this hype in terms of what they do. I just mentioned as an example of this, not only do sort of psychological characteristics seem to change following psychedelic assisted psychotherapy, note the therapy, not just psychedelics, but people really come away with this feeling that something really truly transformative or personally meaningful has happened. So this is a nice study that was published by Johns Hopkins back in 2018. This was a non-clinical sample. That means they weren't taking people with depression or anxiety or whatnot. They were just taking so-called healthy normals. But these were people, all of whom had a daily religious or spiritual practice. And I think it had to be more than 2 hours a day. So it was, you know, they had a bona fide daily practice that they adhered to. So obviously spiritually oriented people. And 2/3 of them, 14 months later, over a year after being given a single dose of psilocybin, reported that it had been among the top 5 most spiritually significant experiences in their lives. So, you know, these people were really carrying something, this feeling that something really important had happened to them within this. Now, I've mentioned psychedelic assisted therapy or psychedelic therapy. There are other ways, or there were other ways that people were trying to use psychedelics, particularly back in the 1960s. So in the 50s and 60s, when psychiatry was dominated by psychoanalysis, one of the major tenets of psychoanalysis is this idea of ego defenses, right? So the ego defenses are the things that when we bring them into therapy, there's sort of these blocks that prevent us from sort of going deeper and working through material. And there was another strategy that was the initial way of working with psychedelics, where people were given kind of lower doses of psychedelics. They weren't, this wasn't microdosing, but they weren't having sort of a full-blown psychedelic experience. So they would give them kind of a moderate dose. And the idea was that it would break down ego defenses and basically let them, let the psychoanalyst have much more productive sessions with the patient by breaking down these ego defenses. And there are some underground guides that still kind of use psychedelics in this way. But in the late 1960s, on the heels of about 15 years of research, there came this idea of let's actually use much higher doses of psychedelics. This sort of came about with, there was this whole idea of transpersonal psychology. There was humanistic psychology under Abraham Maslow. There was a lot of sort of kind of 1960s-ish stuff happening in psychiatry as well. It sort of dovetailed nicely with psychedelics. And the prevailing idea by 1968-69 was let's actually give a very high dose of a psychedelic, facilitate a transcendent experience. And the therapist's role in this is really to just sort of be there for the patient, hold the space, if I can use that term, but really to let the patient kind of let the experience drive whatever is going to happen. Therapist isn't not important. The therapist's role mainly in this, there was extensive preparation. People would usually have weeks of preparation going into this. And then there would be what are called integration sessions afterwards. So, you know, all this stuff happens to you when you're on the psychedelic, you have all this interesting stuff that you want to think about. And then many days afterward, every day, you would meet with your therapist and kind of process what happened and try to integrate this peak experience into your life and try to make meaning of it. And this really is the model that's been used, this model of psychedelic assisted therapy that's been used in most, in fact, really every study that you've heard about that's come out in the last 15, 20 years in this wave of research has used essentially some version of this model, sometimes mixed in with some other therapies. But this is kind of the basic model that we use. All right. The 1960s, particularly in psychiatry, were not ethical peak in human history. So unfortunately, there were a lot of really terribly designed studies that didn't really use any therapy model at all. This study here, I won't read this, but it's done in Toronto where they gave people 800 micrograms of LSD, which is a really high dose. So for reference, 1 tab of LSD is about 100 micrograms. Usually for a psychedelic therapy session or recreational use, people are usually taking around 200 to 250 micrograms of LSD. So they gave them 800, which was a dose that was so high they were giving them intramuscular injection beforehand of Dilantin to prevent seizures. They would tie them to the bed, gave them a blindfold, and really had no therapy whatsoever. So this is actually an alcoholism study, and unsurprisingly, they did not get very good results with this strategy. And this study was, I'll mention, it was criticized by a lot of people at the time. It was sort of a notorious case, but research was not what it is now. All right, so I kind of mentioned this idea already of psychedelic assisted psychotherapy. It was developed by somebody who's mentioned, again, to refer to Michael Pollan's book if you've read it, named Stan Groff, who did thousands of LSD interviews with patients in Maryland in the 60s and early 1970s, mostly people who were suffering either from alcohol use disorder or people who were suffering from depression, anxiety associated with end of life. So he was really kind of the pioneer of developing this model that I already described to you. And alongside him, some of the Timothy Leary and some of his people really kind of emphasize this idea of set and setting. So set just refers to mindset. So that's really kind of utilizing preparation and utilizing suggestibility. So really sort of suggesting as much as possible that this is going to be a meaningful experience is an important component going into this. And setting. So they were finding in the 50s and 60s that when they were conducting psychedelic treatments in sterile looking hospital rooms, people were much more likely to have kind of a paranoid reaction than if they did it in a nicely more humanized, more furnished room. And so really the actual environment, and this has been studied, makes a really significant difference. And so, you know, this is not, it doesn't have to be done in a private practice setting like this. This is obviously particularly nice. Most of the studies, obviously, that are coming out are being done at academic medical centers, but they do, and you can kind of, there's some cool YouTube videos that are, you know, at a really high speed where you can see them going into a hospital room with a hospital bed and then just sort of bringing in furnishings for the day of the medicine visit, which is what they call it. So they'll bring in quilts, they'll bring in a carpet, you know, they'll put some furnishings on the wall, some curtains, just something to humanize the room so that it doesn't look sterile. And that actually does make a difference. So I'm just going to go through a couple of the clinical studies for some anxiety disorders and depression. This is a study that was done at Imperial College in London, looking at psilocybin-assisted psychotherapy for treatment-resistant depression. So that just means that they had to have failed a certain number of depression treatments already. Now, this was not a blinded study. It was open label, so everybody knew that they were getting psilocybin. Okay, so there's some limitations to a lot of these studies, which are small studies. The sample size is small, and they were open label. So you have to take these results a little bit with a grain of salt, but the impressions nonetheless were impressive. So they gave them 2 doses of psilocybin 7 days apart. The first dose was kind of a small dose, sort of like halfway in between microdosing and macrodosing. Really, this was to sort of help the patient get used to what the experience was going to be like before they gave them a 25 milligram dose. They utilized that model of preparation and psychological support that I already described. And then they followed them for about 5 months after the study concluded. And they found that depression scores decreased really significantly and that there was some sustainment here. So what you're looking at, the BDI up here is one of the many measures of scoring severity of depression. So if you look in the top left here, the baseline average score of these subjects was 34.5 on the Beck depression, the BDI. And that's pretty significant. So once you get into the 30s, you're dealing with pretty severe depression scores. And then 1 week out, you can see there's a drop down to 11.8, that's average. So a really rapid drop 1 week after the second dose. There's a little bit of a creep back to almost 20 at 3 months, but this is still a really substantial drop, particularly when you consider that this is really kind of a 1 week therapy. They got 2 doses of psilocybin, 3 months out, there's still this change, which persists up to 6 months out. And these were people to be in the study, you had to go off all medications, stay off medications during the study period. So this is actually, nonetheless, a really impressive result. And this group is teasing that they have a new publication that's going to be coming out soon in New England Journal of Medicine, where they actually did a head-to-head comparison of Lexapro, an antidepressant, versus psilocybin-assisted psychotherapy. So stay tuned. That's going to be, I think, a widely covered study when it comes out. This is kind of a similar design, but it's a randomized controlled trial that was double-blinded. So this was a much better quality research. They only followed their folks for 1 week out. I think there's going to be a longer-term follow-up, but you can kind of see. So the ayahuasca line, you're just looking at severity of depression. They used a different score, the MADRS, instead of the BDI. But again, these are people with really severe depression, and they were given ayahuasca. Now, when I've talked about the model of the psychedelic-assisted psychotherapy, you have to step back and consider the fact that the placebo groups are still getting multiple days of special therapy with 2 psychedelic therapists. Then they're sitting in a room for 8 hours with 2 therapists. They just got placebo instead of ayahuasca. And then they still get all the integration sessions afterward. So if you're in the placebo group, you're still getting a ton of hours of psychotherapy. You're getting like half a year's worth of therapy compressed into about a week. All right. So it's unsurprising that in the initial days out, both of the groups actually have a substantial drop in their depression scores. We shouldn't be surprised at this, but what you see, the blue line by 1 week out, they're starting to separate. So that's when you actually see statistically significant differences in the scores of depression in the placebo group versus the ayahuasca group. The ayahuasca group drops rapidly, they drop more, and they stay down, whereas there's sort of an initial response, placebo, but then the scores start to creep back up. This is obviously a busy slide. I'm not going to go through all the text here, but it's just to say that on the heels of all of this research that was done in the late 60s and early 70s before the curtain came down on psychedelic research, one of the most promising areas that was just sort of beginning to expand when the federal government cut off all the research was the work of Stan Grof, looking at people treating existential related anxiety and depression associated mostly with terminal cancer and some terminal heart disease with LSD therapy. This is a really promising area and it got kind of cut off. So there were a couple of studies that came out in the early 2010s, and then this pair of studies that was really impressive. So these are really nicely designed clinical trials. They did their best with a placebo, which is very difficult, as you might imagine, in psychedelic research. But one study came from Hopkins, one study came from NYU. They were separate studies, but they kind of coordinated with each other. They used very similar protocols. And really the highlight of this is that these were people who had either depression or anxiety disorders associated with terminal cancer, and they were medically, fairly sick. They got a single dose in each study of psilocybin, and 6 months out, they still had a very significant reduction in anxiety and depression. So 80% for both anxiety, depression in the Hopkins group, 60 to 80%. One refers to anxiety, the other refers to depression. I can't remember which one was which in the NYU group. But this is 6 months out, and they actually, in January last year, came up with a long-term follow-up with the survivors. I think it was the NYU study with the survivors. And the folks who had continued to survive were still reporting, several years out at this point, substantial reductions in anxiety and depression. These were literally life-changing for these people. So I think this is one area that's particularly promising. And there's some research that's going on in larger trials looking at this right now. Now, switching gears to addictions, another difficult area in psychiatry. Early research using LSD in the 1950s started up under this guy named Abram Hoffer. So he was just a psychiatrist out in Saskatchewan, somehow got a hold of some LSD, and the prevailing theory at that time was that delirium tremens, this horrible syndrome that chronic alcoholics can get if they don't drink. At that time, it was thought delirium tremens could be a good thing for an alcoholic. You basically go through this horrible withdrawal delirium, and you facilitate a rock bottom experience, and that's going to help turn them around. So this is not true. There's no evidence to show that this actually works. Nobody thinks that way anymore, but that was the initial theory. Alongside that, there was this idea, well, LSD might be horrible, so let's give these people this terrible experience with LSD and sort of help basically create a rock bottom scenario where they'll turn around from their drinking. They ended up finding that these people were having quite the opposite. They were having really positive experiences. And due to that, in Saskatchewan by the late 50s, it was basically the standard of care for a few years to treat alcohol use disorder using LSD therapy. Now, Bill Wilson is the guy who wrote the big book of AA. He's the person who founded or co-founded Alcoholics Anonymous. Bill Wilson knew Aldous Huxley, who wrote The Doors of Perception and who had had really powerful experiences with mescaline. There was kind of this circle in California. This was before psychedelics kind of got into the hippies and the counterculture movement, but there were some kind of high society circles in California that were using psychedelics. Aldous Huxley was part of that. He was friends with Bill Wilson and ended up giving Bill Wilson, the co-founder of AA, or connecting him to somebody who gave him LSD in 1956. And this completely blew Bill Wilson's mind. And he then went up to Canada because he found out that it was actually being used to treat alcoholics and spent some time up there. And Bill Wilson basically became convinced that LSD should actually be incorporated into the formal Alcoholics Anonymous treatment model. And this caused a fair amount of controversy. Obviously, it didn't happen. The board of AA was staunchly opposed to it. So it was sort of a controversial thing with Bill Wilson running around trying to advocate to put LSD into the treatment model. But he has this interesting quote here where he says, "I don't believe LSD has any miraculous property of transforming spiritually and emotionally sick people into healthy ones overnight." So he's not being unrealistic. He doesn't think it's a panacea here. What he says is it can set up a shining goal on the positive side. After all, it is only a temporary ego reducer. The vision and insights given by LSD could create a large incentive, at least in a considerable number of people. So he basically thought that LSD could sort of help inspire people to move forward with their recovery, sort of give them a starting point for it, but not actually do the curing itself. There were a ton of studies looking at alcohol use disorder in the 1960s. And somebody actually in 2012 went back, did a meta-analysis of all these studies and found that there was actually about 1.96, an odds ratio of reducing alcohol misuse, as they had to call it. So essentially, yes, the LSD therapy was actually effective for alcohol use disorder. Now, this was a study in NYU that came out in 2015. Again, this was an open label study. They basically took psilocybin therapy, they put it into a motivational enhancement therapy, which is kind of like motivational interviewing, to see if it would reduce heavy drinking days. They had some very promising results. You see sort of kind of the similar thing as a rapid drop in drinking, and then it was sustained several weeks out. And they are just wrapping up now. It got delayed a little bit by COVID, but an actual proper double-blind phase 2 trial of psilocybin-assisted treatment of alcohol dependence, as they call it. So we should get the results of that one fairly soon. This was a study from Johns Hopkins where they took people who had previously tried to quit an average of 6 times to quit smoking. So the smoking cessation trial, again, open label, you have to take this with a grain of salt, but really impressive results. This was a model, they took kind of a smoking cessation cognitive behavioral therapy, mixed in some psilocybin therapy, and then they followed them and they verified abstinence through urine assay. So you can actually make sure that people haven't been smoking within the last 7 days. So they definitely were abstinent. So at 6 months, 80% of these people had completely stopped. And then they kept following them. So at 12 months, 2/3 had continued to stop smoking. And at 30 months, 60% had continued to stop smoking. So these results blow really like anything else that we prescribe for smoking cessation so far out of the water, it's not even funny. Again, it's an open label study, small sample size, we need more data, but there's really nothing else that's ever been done where you would get a result like this. You might want 100%, but 60% for smoking cessation is really nothing short of incredible. I'm just gonna skip this slide in the interest of time. So just talking a little bit about mechanisms here for the final part. The question that a lot of people are curious about is, why is it possible to put a drug into our bloodstream that can produce this crazy effect that psychedelics produce? Like, why is there actually receptor machinery in the brain that can actually do that? And why the 5-HT2A receptor, that serotonin receptor I talked about? So really, one of the prevailing theories that I think is most interesting is this idea that based on animal models, this receptor system seems to turn on if you really, really, really stress an organism. Okay, so take like a rat or a mouse and you just like stress it to the max, it seems to turn on the 5-HT2A receptor. And so there's this idea that if you have this organism that is facing a truly existential threat, in that moment, that organism needs to completely unlearn tons of stuff that is very deeply held and sort of as like a pattern of behavior and a pattern of learning. So it needs to induce a state of neuroplasticity. You need to sort of rewire the brain across many different ways in order to have the organism be flexible enough to completely unlearn, you know, like this environment is no longer safe. It needs to change its feeding patterns. It needs to change its it needs to adapt very quickly. And so if you think of psychiatric disorders, particularly anxiety, depression, and addictions, as sort of learned patterns of behavior or learned thinking patterns, inducing a state of neuroplasticity using this receptor system may be actually allowing people to completely unlearn these sort of thinking ruts or these patterns of behavior very quickly. So that's one theory. It's a lot of other theories in terms of the fact that the amygdala, which is basically our fear center in the brain, is actually loaded up with 5-HT2A receptors. And so the amygdala is sitting there basically determining all the sensory information that's coming into the brain. The amygdala is help tagging it if it's good or bad. Is it a threat? Is it not a threat? It's closely involved in both depression and anxiety. And so there may be some modulation of the amygdala sort of determining things as threat that's being reduced. And that's regulated by the prefrontal cortex, also interestingly through 5-HT2A. This idea of the default mode network. So the default mode network is a network in the brain. There's a lot of different brain networks, and they're basically just different parts of the brain that turn on or turn off during specific tasks that you're doing. So there's many different networks. This particular network actually turns on when we're just daydreaming. You just sort of, you put people in an fMRI scanner, the way you look at the default mode network is you just tell them to close their eyes and think about absolutely nothing. And that's what actually turns on the default mode network. The default mode network also is thought to be very closely involved in our sort of sense of self, our sense of embodiment of sort of physical space, retrieval of autobiographical memory, when you sort of ask somebody to sort of think about themselves and like talk about themselves. And it's also involved in daydreaming. What's interesting is this network is abnormal in people who are depressed and people with addictions and really a variety of other mental health related conditions. And what's also interesting is that this seems to be the network more than any other network that gets disrupted by psychedelics. So the whole network gets disrupted, the activity gets turned down, the different parts of the brain that make up the network stop talking to each other as much. And this has been shown with multiple different psychedelics, this modulation of the default mode network activity. So these are just some pictures showing this. But this is the same Brazilian group that I mentioned with ayahuasca earlier. So they basically found decreased default mode network activity. This has also been found by the group when they compared psilocybin and ayahuasca, and kind of the same thing. They find significant default mode network functional connectivity decreases. What does that mean? That means that you have different parts of it, and they're just not talking to each other under the influence of the psychedelic. So it's interesting that this network that's involved with the sort of idea of sense of self and sense of embodiment, when you think about this concept of ego dissolution, this is the network that's implicated. So this is definitely something that psychedelics are doing, and something that we're going to be studying at MGH in our studies once they get going. Finally, this idea of psychological mechanisms. So one thing that's interesting about personality, the dominant way of thinking about personality from the standpoint of psychological research is this idea of big five. So there's 5 personality traits. One of them is neuroticism, but these personality traits are more or less fixed in each individual by the time we're in our late 20s. All right, so these are things, it doesn't matter if you're depressed or you're not depressed, if you're drinking or not drinking, if you're anxious, if you're not anxious, you're going to score the same on things like neuroticism, openness to experience, or introversion, extroversion. All right. However, psychedelics over the long term seem to be changing these personality characteristics, these things that really should be fixed and never change. They're seeing them again and again and again, both with psilocybin, with ayahuasca, with MDMA. They're actually leading to long-term changes, particularly in this one concept of neuroticism, which doesn't mean neurotic, but neuroticism, people who score highly on neuroticism are people who are generally thought to be at risk of developing psychiatric conditions like depression, anxiety, and addictions. These are people that don't do well with stress. They tend to develop negative affect more quickly, and they tend to somatize. They sort of like manifest their stress physically. So we see high scores of neuroticism, not just in things like depression, anxiety, PTSD, alcoholism, substance use, but we also see it in psychosomatic and functional disorders, and sort of physical disorders and somatization related disorders. So this is really interesting that this trait that really shouldn't change over time is deeply and over the long term modulated by psychedelics. So the psychological aspect too. Just in terms of future directions, I think last year was kind of a watershed. So we had the opening of Johns Hopkins launched their center. The world's first center opened in Imperial. I think that might have happened in late 2019. This is just the screenshot here is a review of psychedelics published in the American Journal of Psychiatry. So this is sort of like, you know, a major change that this is sort of the main journal in psychiatry that they would publish this. So obviously psychedelics are really entering into the mainstream. And like I mentioned, I think at the beginning, we just launched our center last week with Michael Pollan. This is just the leadership of our center. Jerry Rosenbaum is leading the charge here. Really some phenomenal people and hopefully some phenomenal research that we'll be able to talk about in the next couple of years. So with that, I will stop and hopefully there will be some questions that we can talk about. Thank you.
Okay, thank you, Dr. King. I think it's safe to say that, especially for anyone who remembers the Timothy Leary era and the backlash, your presentation is full of ideas that are really mind-blowing, even when one is stone cold sober. Gay, can you please take people off mute? And we'd like to welcome people to ask live questions if you like, and I will also read the questions that are coming in on chat. And we will end by 3:30, but we've got plenty of time for some questions and answers. Would anybody like to speak up with a question?
Yeah, sure, I will, if that's okay. Hi, Franklin. It's Katie Bond.
Hi, Katie.
Hi. The question I have is, why are people with serious mental illness, such as bipolar or schizophrenia, more or less excluded from this? Because I keep wondering whether the kinds of delusions and paranoia they have might not somehow be altered to a kind of positive extent with this therapy. I'm just If you could talk
Excuse
about
me a minute. I think I should interject here. The master muting is now over, but we're getting feedback from somebody's environment. So if you're not actively speaking, please put yourself on mute. And when you want to speak, just take yourself off mute. Okay, thank you. Go ahead, Franklin.
Yeah, I couldn't hear the very last part. I heard most of it up until the final part. There was a word about delusions, and I didn't hear that.
Well, I just wanted to say, I just keep wondering whether people with serious mental illness might not be helped with the kinds of delusions and paranoia they have, be helped through psychedelic experiences, have their delusions altered somehow to something more positive. That's all. So
yeah, I mean, I think it's a great question. It's a complicated one. I think one thing that's really important, I think a lot of the kind of negative psychological things that can happen on psychedelics really do tend to happen in sort of non-structured settings. So I think there really is a big difference, not for everybody. I think, plenty of people, not all recreational use, I think is unsafe, although I would never recommend recreational use, but there are people who do it and they're fine, but the risk of something bad happening is greatly increased. And there really is a difference between people just taking psychedelics on a camping trip versus actually going in and getting all of the therapy. And the integration, the therapy that happens afterward, is also really important. And so people often will sort of have, if they have a negative experience, or sometimes they'll have a really positive experience, and they can sort of develop this grandiosity after psychedelics, where they might just want to give everybody psychedelics or tell everybody how great they are. And I think that's where the integration becomes incredibly important. Now, I'm saying that because I wouldn't be surprised if, 10, 15 years down the road, when we have a lot more information on how psychedelics work and who's at risk of having bad things happen, we might be able to safely give psychedelics to people that right now we think are at much greater risk, like the folks that you mentioned, people with delusions or people with bipolar or schizophrenia. My guess is that eventually we probably will, but there's going to have to be a lot more kind of integration and preparation. Now, I didn't talk anything about MDMA, but MDMA is a little bit different. I think, some people would argue that it's not really a true psychedelic. It certainly doesn't make people sort of hallucinate or sort of have the experiences the way people do on LSD or psilocybin. It's more of what's called an empathogenic drug. And so it sort of opens people's hearts up. It makes people feel much less fear, much more trusting towards others, much more sort of pro-social. And so it's an interesting drug. And somebody has, I don't know where they're at with this, but I've heard about this. At Columbia, somebody has proposed treating negative symptoms of schizophrenia with MDMA. So schizophrenia is not just hallucinations and delusions. Those are the positive symptoms, the things that are present that are not present in healthy, normal people. But negative symptoms in schizophrenia are the symptoms of things like social withdrawal, sort of decreased attention to hygiene, decreased interactivity, sort of just more apathy. And negative symptoms in schizophrenia are really difficult to treat. We don't actually have good drugs for those. And so there's been this proposal of this idea of, could we use MDMA specifically, which is not really quite so psychedelic. It doesn't knock out the whole sense of self and make people hallucinate or experience that visual stuff that LSD does. But could you use this sort of heart-opening, empathogenic effect of MDMA to treat negative symptoms? And I think that's a really compelling idea. But I would be surprised if an IRB approves a study like that anytime soon. I think really in the interest of safety, we do need to know a lot more about psychedelics before we start testing people that could be potentially vulnerable to some adverse effects now. So we'll just have to see.
Thank you.
Let's go to a chat line question now, and then we'll go back to another live one. Ed asks, is psychedelic treatment in a non-research setting available in the Boston area, or is it limited to research only?
Yeah, so I mean, there are people who, there are underground guides, but in terms of sort of legal treatment, psychedelics are all categorized under the DEA Schedule I drugs. So they're drugs that have, according to the federal government, no medical purposes whatsoever. And the only way to study them, and for this reason too, research is really difficult with these things. It's not like just studying, if you wanted to do a study with, oxycodone, which is, I think, Schedule 3, or even Ritalin, which is Schedule 2, or no, Ritalin Schedule 3. So, I mean, working with controlled substances is difficult, but working with a Schedule 1 substance, it's crazy. I mean, you have to have a special safe. It has to be bolted to the floor. It can't be in a room that has an exterior wall because of all the people that are going to try to be blasting open the wall to steal your psychedelic drug. You have to get a special Schedule 1 license from the DEA, which takes a long time. So the federal scheduling really actually is hampering research in this field and making it proceed at a much slower pace than it would. That's more editorial that you didn't ask for in the question. But the short answer is no. Psychedelics, because of the fact that they're illegal, you can only get psychedelic therapy legally in a research study at this point in this country.
And Franklin, in the Boston area, is it Mass General only that's doing clinical studies in psychedelics?
Well, yeah, so MGH is the only institution at this point, but there is, and there has been for a long time before, a MAPS study site in Cambridge. And so MAPS is the multidisciplinary association for psychedelic studies, run by Rick Doblin. And they have been spearheading a huge series of clinical trials on MDMA-assisted psychotherapy for treatment-resistant PTSD. And this is a multinational, multi-site study, and there are 6 pairs of MDMA therapists in the Boston area. So that study is ongoing, but it's through MAPS. It's not through a specific institution.
We have another live question. Would someone like to speak up?
I did.
Austin?
Franklin, if Timothy Leary were here today saying the kinds of things he said in the 60s, would your reaction to him be right on, Tim, or be careful, Tim?
Yeah, I mean, I don't actually, I don't know a whole lot about Timothy Leary. I mean, I know enough about him, I think, to answer that question, but I think he was obviously controversial. I think a lot of the stuff that he did was irresponsible, and it did set the field back. On the other hand, I do think he brought psychedelics to the awareness of the public, albeit in a not responsible way. But I do think he left a not altogether negative impact on the field. While at the same time, I think his sort of chaotic, like encouraging college kids to drop out and take acid, really turned off a lot of people in America and probably helped the kind of media frenzy against psychedelics. I mean, he also, I think the thing that I like the least about Timothy Leary is he basically, he had his position at Harvard. He was supposed to be teaching, and he just didn't show up to class. The guy wasn't going to work. He was just hanging around giving people LSD if they came to his house. So that's just kind of shady.
Yeah.
Here's a question from Susan. Oh, I'm sorry. Yeah. Let's take one more from the chat line, then we'll go back to live. What causes a bad trip, and can you control for it or identify patients and situations ahead of time who might experience it?
So, yeah, I mean, I sort of alluded to this in talking about that earlier, but I think there really is no such thing as a bad trip per se. It's that really, I think the idea of the psychedelic assisted psychotherapy, a lot of the preparation is really having people understand that they need to be open to whatever experience comes up. Once the person's in it, there's very little control that can be put upon the psychedelic experience. The point is really more to be able to surrender to the experience and to trust in it and to simply be there, essentially almost the way you would be meditating, to simply, let thoughts come and go, be aware of them, see where they lead, be curious about them, be open to them, but whether they're negative or not. I think where people get into trouble with these so-called bad trips are they sort of try to psychologically clamp down. They're like, oh my God, this is terrible. Like, don't think about this. Don't think about this. Like, have these thoughts go away. And trying to think in that way on psychedelics tends to create a lot of distress. And so it's not so much identifying people that are going to have a bad trip or not. In that smoking cessation study, a lot of people had very negative experiences, but they actually, when they were interviewed at the end of the study, it was the negative experiences that really helped them. And it's not just that like, this was horrible, that made me like hate my smoking self and I stopped. It was that the negative part of the experience, when they sort of explored it, really led to deep personal insights that they were able to integrate into their daily lives. So you don't want to sort of encourage people or discourage people or sort of think about things in that way. It's more just, you have to be curious and you have to be ready for anything.
Guys, let's have another live question. Just raise your hand if you're interested. I'll try to.
Yeah.
Go ahead, Tony.
Yeah, so Franklin, I didn't quite catch what you were saying about daydreaming, and that was sort of in passing, except that I'm trying to wrap my head around something. The fair number of creative people and people who know creative people think that their creativity is largely linked to their neuroses, and they want to hang on to their neuroses for fear that they'll lose their creativity. And so maybe they are people who, through the neurotic process, can access certain experiences that they can, I don't know, write about or use. But I think their partners might like them to get rid of the neuroses and maintain the creativity. So what do you think psychedelics would do for that process?
Well, so first of all, we have to differentiate between what you mean when you say neurosis versus this trait neuroticism, which is sort of one of these 5 major sort of slices of personality, which is different. I mean, I think probably most people who have what most people in that person's life would call a neurosis probably would score more highly on trait neuroticism than your average person on the street. But I mean, I don't think psychedelics aren't like erasing personality. Like, these aren't people that sort of come out and, I mean, they feel different and they feel changed, and people in their life might notice that they seem a little different, but they're not turning them into a different person. And I think the experience of people coming out of these studies is not that they've been changed for the worse, is that they've been changed for the better, whatever that may be. An interesting thing, in the 60s, there were some studies, I think they actually had sort of inconclusive results, but they actually did some studies trying to see, will psychedelics, particularly LSD, actually enhance creativity in artists. And I think there's a group, I don't know about this, but I've heard this through the grapevine, that there's a group being funded by some Goldman Sachs people looking at doing something using LSD to enhance creativity.
That's interesting.
Yeah. So,
Yes.
but I mean, I hear what you're saying, but I think there's a difference, I think, between, real suffering and some of the kind of neurotic stuff that might lead those of us who tend to be on the neurotic side to actually be more creative.
Thanks.
Franklin, have psychedelic therapies been used for anyone suffering from crystal meth use that you know of?
No, there's a study looking at cocaine use that's been going on forever in Alabama, but not seen anything about stimulants.
Right, do we have another live question? Reg?
Hi, Franklin, Reg Foster here. So in my amateur tracking of this area recently, it's my impression, but I'm asking, maybe you could elaborate, that the large scale stage 3 MAP studies on MDMA are closest to completion, and the rest of the psychedelic research is moving along, but with all those obstacles you talked about. My impression has also been that those stage 3 studies are either completed or very close to completion and rolling out this year. I'm asking about the mainstream, not the severely depressed or the severely handicapped, contingent 15 years down the road. But can you, as Mr. Data here, speculate as to how these therapies can unfold into the mainstream? over the next few years? What needs to happen? Because they seem to have an awful lot of potential for an awful lot of help to some hurting people out there.
So there's a lot of things that need to happen. There's a lot of components to that question. The first thing that needs to happen is the FDA will have to approve treatment, or either that or the government's going to have to do what Oregon did, which is to legalize psychedelics and have some sort of or have some process in place for psychedelics to be given out. So for those of you that aren't aware of what I'm talking about with Oregon, I think two separate bills. I think one, they decriminalized all drugs in the last election, but they also approved a bill, the voters approved a bill to legalize psilocybin-assisted psychotherapy. So that doesn't mean that in Oregon, once this rolls out, you're going to be able to go to like a cannabis shop and buy mushrooms. What it means is that the state of Oregon is going to set up a training institute and a certification process for psilocybin therapists to train, get certified. The therapist will be able to obtain psilocybin, and they will be able to offer psilocybin-assisted psychotherapy. So I think it's actually a really cool and innovative law because it actually allows for sort of safe, structured use of this drug. That's one avenue that could happen in Massachusetts, although I think Massachusetts is probably nowhere near that. So the other thing that will need to happen, either in parallel or beforehand, is that the FDA will approve psilocybin-assisted psychotherapy or MDMA-assisted psychotherapy. Both of those are probably about 2 years out. MAPS is doing MDMA. Compass and USONA are two organizations that are both pursuing their own FDA approval for their own therapy, right? So they're not seeking FDA approval for psilocybin. They're seeking it for the actual therapy process with the psilocybin. So once that happens, then you're going to need to build all of the therapy places. And that I think is going to be a challenge. I mean, these are going to be, at least on the front end, these are going to be very difficult to scale. So if big trials can show what these small trials show, that you give people a couple of weeks of therapy and a psilocybin session, and you cure their depression, at least for 6 months or 12 months out, that would be, a game changer. But at the same time, there's a lot of cost up front. So there's going to be a lot of issues with insurance paying for this treatment. There's going to be a lot of issues with access. Who's going to be able to get it? Is it just going to be rich people who can afford this treatment? Or is it actually going to be sort of, distributed to the whole population? And then, the question is going to be who's going to build the centers. I mean, will these places build all of these centers? How many centers will there be? If there are going to be innovations in therapy where you can give these in a group setting and save some money. And then I think, over the longer term, I feel like maybe embedded in your question, I mean, these studies are really looking at people who are treatment resistant for depression, anxiety, PTSD, and the like. But there's a lot of people that want to see psychedelics available just for building resilience. I mean, there's studies now looking at sort of burnout in healthcare workers. There's a study in Washington State that's looking at sort of helping healthcare workers recover from sort of moral injury from the COVID pandemic. And then I think more generally, I mean, things like creativity or just sort of developing a healthier sense of self are also potential things down the road. But I think there's going to be a lot of challenges because it's going to be expensive. The therapy training is expensive. The process is expensive. Who's going to manufacture the drug? There's a lot of stuff that needs to be worked out. We're pretty far from this, to be honest with you.
More live questions?
I have one.
Okay, I'm not sure who that was.
It's me.
Mary.
Yeah. I was wondering what kind of treatment regimen the patients in the trials were on when they entered the trial, whether they were on psychopharm treatment or if they had to surrender the treatments they were on. What was the profile of patients participating in the trial?
So every trial, people have had to have tapered off all psychiatric medications, and really for a long time out, because for things like SSRIs, you really need to be off them for 8 weeks or more before they're truly washed out of the system. So You might imagine, I mean, for example, for the MAP study for PTSD, these are people who have to have really severe and treatment-resistant PTSD, but they also have to be able to sort of come off all their medications. So, you know, recruitment can be an issue if you sort of want to get like the sickest of the sick in a study, but you also mandate they come off. But I mean, there's a few reasons for it. One is just that if you have other drugs on board, every patient is going to be on a different regimen, and so it's a confounding factor. But also a lot of psychiatric medications either have a negative interaction with psychedelics, or in the case of SSRIs, they'll block the effect of the psychedelic.
So that's
Harkins, you look like the Wizard of Oz there with the LSD molecule behind you. Did you have a question?
Yeah, I had a couple of things. During the 50s, there were a couple of people of some prominence undertook undertook tests for LSD. One was Whitey Bulger, James Whitey Bulger, who was tested in Atlanta when he was in prison. And in his trial, they sort of didn't bring up a defense, but is any results of that trial, that clinical trial or whatever it was that would point to a defense for him? You know anything about that one?
I missed just a little sliver of what you said. What did Whitey Bulger do?
He went under a LSD test in Atlanta in the 50s, Atlanta prison in the 50s. And they sort of used it they tried to use it as a defense for his activity, blaming the government or something like that. Do you know any results of that trial? Was it very...
I think I don't. I mean, there was a experiment done by Timothy Leary at the Concord prison, the one at the Rotary. That's the only prison experiment that I'm aware of. But I mean, I think it's a pretty flimsy defense for the late Whitey Bulger.
And the other person who was involved was claimed it enhanced his creativity was Ken Kesey. Because he, in the 50s, he went in and he claimed that part of One Flew Over the Cuckoo's Nest, I think the green mist part, was written under the influence of LSD, right?
Yeah, I think
later on he did his own clinical trial with the electric Kool-Aid acid test and the Merry Pranksters. But is there any evidence you think you sort of answered this question before, that it enhances creativity or doesn't?
We don't have any research, I think, that proves that it increases creativity. I think people who have been exposed to psychedelics would probably say, yes, it does. I mean, I think, for example, probably the most famous case is the guy who invented PCR, which we've all been very thankful for this year to get COVID tests. Sort of had this eureka moment when he was on LSD that led to him developing polymerase chain reaction and eventually, I think, getting the Nobel Prize for it. But I don't know if we could just say sort of like bluntly that psychedelics increase creativity for everybody.
Okay. Any other questions live? We've got some more in the chat line. All right, let's go. Go ahead.
Franklin, what a terrific presentation. Thank you. Really well done. Could you comment a bit on its effect on PTSD?
Yeah. So I just in the interest of time, I didn't do any slides on PTSD, but I mean, really the most impressive out of all the psychedelic literature is this MAPS work using PTSD. I mean, they're taking people with extremely severe post-traumatic stress disorder. Their phase 2 study that they published a couple of years ago in the Lancet really only looked at first responders. So I think there were 20 people and like 18 of them had combat trauma, and then one was a firefighter, one was a police officer. And very, very, very high PTSD scores and very dramatic reduction. Now they got, depending on the arm, they got 2 or 3 sessions of MDMA, but still they did a 45-month follow-up, I think. And the majority of people who had gone through that trial still no longer met criteria for PTSD at all. It wasn't just they reduced their symptoms, they actually didn't even meet criteria for PTSD. So that, they're doing 2 phase 3 studies. So one they just finished, they haven't quite published it yet, but they got similar results. And when they finish the second one, it's very likely, I mean, almost undoubtedly, the FDA is going to approve it. But again, MDMA is a little bit different than a classical psychedelic. Like I mentioned, it opens people up. It makes people feel more trust and less fear. So I think it's uniquely suited for working. With PTSD, there is going to be a psilocybin study somewhere in Europe, I think in the Netherlands, that's going to be using psilocybin for PTSD. But I think MDMA is particularly well suited for that. So I'm actually one of the principal investigators on a study. We're still sort of working out. We haven't finished. It's partially funded, and hopefully in a few months it'll be fully funded. But it's going to be a study. Actually, I'll answer my mom's question, which I saw she typed in there. Hello, Mom. At MGH's home base. So home base is affiliated with MGH. It's this huge organization. I think it's the largest veterans clinic or non-VA veterans clinic in New England. And so we are going to be doing a study through MGH home base for veterans with PTSD using MDMA assisted psychotherapy. So it's a really promising treatment, and hopefully there will be more opportunities. I know Rick Perry is really interested in sort of helping this along. There's this ever-growing stream of veterans that are actually going to San Diego and crossing the border into Mexico, where there's these treatment centers using psychedelics, specifically for Navy SEALs. They're run by Navy SEALs, and they're going south of the border, where they're doing ibogaine and 5-MeO-DMT treatments for their PTSD. But veterans are beginning to sort of wake up to this too. And it's one of the most promising areas of research, actually. So glad you asked that question.
Here's a question about ketamine, which is, I believe, approved by the FDA for other purposes. Is there a reason you didn't talk much about it? What is your opinion of it for adolescents? And what would you say to psychiatrists who are extremely resistant to its use?
I didn't talk about ketamine because it's different than classical psychedelics. It's, works differently. It doesn't induce a psychedelic state to the extent that I think things like psilocybin do. That being said, I mean, the one thing I would say about ketamine is that the way it's done is very sort of pharmacologically focused. And so, I mean, there are places at MGH or McLean where they actually have, psychiatrists running this. But I mean, most ketamine clinics in the United States are not actually run by psychiatrists. They're run by anesthesiologists. And you go in and, you go into a room, they give you the ketamine, and then you leave. And there's not actually sort of any psychotherapy. It's not done the way like psychedelic assisted psychotherapy is done, where there's preparation sessions, where they give you a high dose and there's sort of 2 therapists present, and music is part of it, which I didn't talk about, where there's this sort of whole package. Now that does exist. There are people in Cambridge who are practicing ketamine assisted psychotherapy using the psychedelic model. And to me, I think that's potentially promising, although I haven't worked with it myself. As a psychiatrist, I mean, for example, I mean, I have a patient who went to a local ketamine practice and talked to the doctor before getting the ketamine and said, my depression is like this. I have these particular symptoms. Is ketamine going to be good for this kind of depression? And the anesthesiologist said, I'm an anesthesiologist. Like, I don't know about different kinds of depression, but like the drug works. So like, here you go. And that's pretty disheartening to hear. So.
Okay, more live questions, Reg?
I'm allowed a second one. I'm glad you mentioned psychiatrists, and so I want being conservative comes with the territory, I think, in fairness. Can you speak to the your profession in a broader sense, and where they stand with respect to this pretty revolutionary research that's been going on here for the last few years. Finally been going on.
Yeah, I mean, I think definitely, it's funny you say that. I mean, I think psychiatry tends to be more conservative than the rest of the medical profession. The medical profession tends to be fairly conservative as well. But you might think that, psychiatry having to sort of be very open-minded about things with patients would be open-minded about treatments. But I would agree with you. I think it tends to be a little bit on the conservative side. I think the thing about psychedelics that really inspires me is not just that they work, or that they seem to work, but that people time and again, it brings people in touch with things that really matter to them. And it highlights things that I don't think medicine in general tends to pay much attention to. Things like connection, meaning, fulfillment, really, the big stuff, the simple stuff, the big stuff, the really important stuff. And it helps people reconnect with stuff that they really might have been disconnected to. And in that way, they work a lot more like therapy than they do like a pharmacological agent. I think the challenge for psychiatry, and really probably the challenge for medicine, is that we work in this kind of Western medical model where we sort of react to symptoms and we try to suppress them. And psychedelics really don't suppress symptoms. They sort of help people work through things rather than sort of turning symptoms off. And so, when I talk with psychiatrists, I think there's going to be a challenge kind of communicating how different this treatment model and kind of what the underlying ethos of it is, how different it is from sort of conventional treatment. This is not just sort of, because you have this kind of depression, you're going to get psilocybin. If you have this kind of depression, you're going to get ayahuasca. It's focusing on deeper things, and in a way that I think is different than kind of, the 1980s, 1990s psychopharmacology. So I think that's going to be a challenge, both to communicate how it's unique, both to the profession, but really also, I think, to most people.
Okay, well, we have less than 5 minutes, so let's do a little lightning round. Do you have any comments to make about current studies with schizophrenia, microdosing? Any comments on either of those briefly?
Yeah, so schizophrenia, no studies that I know of. I mentioned earlier, there's somebody who has an idea of doing a study that I've heard about at Columbia, but I don't think that's going to happen anytime soon. Microdosing's tough. I mean, some people swear by it. The data that we have is limited, but basically there's a study that just came out that showed the people who benefited from microdosing were the people that expected they were going to benefit from microdosing before they started doing it. So, how much it works versus how much there's a placebo effect is not clear at this point.
Okay, let's make this the last question. This is a great question. Some anxious people use marijuana daily to alleviate their anxiety. Should they try psilocybin instead?
Oh, no.
Yeah, I mean, I think in general, it's hard. I mean, I work in an anxiety clinic, and I have a lot of people come in and sort of want psychedelic therapy, but that's not something that I can offer because there's really no way outside of a research study to do it. So I think, I mean, in general, I have to say I wouldn't recommend that people go just take psychedelics to treat anything because of the reasons that I already mentioned. I think they are definitely safe when they are used in the appropriate context of the therapy structure that I described. The problem is that therapy structure that I described is really difficult to find outside of a research setting. But the potential for sort of an adverse effect or consequence is definitely a real one if people are going to take it sort of outside of that structure.
Okay, well, thank you very much, Dr. King, for sharing your expertise with us. And thank you to members of the audience for coming to learn more about this important and hopeful topic. Just a reminder that you'll be able to find a recording of this presentation on the Needham Library website either tomorrow or Tuesday. And thank you, Gay Ellen, for doing that for us. Before we go, the Friends of the Library would like to invite you to the last program of our current season. On Sunday, April 25th, Boston Globe columnist Beverly Beckham will speak on Zoom about the evolution of a columnist. We'll see you then, and thanks very much for coming today. Thank you, Franklin.
Thank you.